disorders which reflect upon the chest film. What are the various classifications of systemic disorders? Congenital or developmental, infections, very common, hematological, metabolic, miscellaneous, neoplastic, leukemia, lymphoma, myeloma, and metastasis. We are excluding local causes. Chest comprises of, when we say systemic disorders reflecting upon the chest, what are the structures in the chest? Thoracic cage, lungs, pleura, heart, and mediastinum. First, let us take congenital or developmental abnormalities of the skeletal dysplasias. The sclerosing dysplasia, that means marble bones, osteoporosis, diffuse sclerosis of the bones. So, why we have taken up chest is the most common type of radiograph that is taken in general hospitals. Even in special hospitals, say cardiac care or nephro care or gastrointestinal care, still minimum examination they take is a chest radiograph. Because for pre-anesthesia checkup or for any other systemic disorder, chest radiograph is essential. And then incidentally, what do you find? Well, if you take a chest film, if the dense bones are sclerotic and opaque, you think of osteoporosis first. Not other disorders do not produce sclerosis, but the first thing, if it is diffuse, including clavicles, proximal ends of the humeri, vertebra, you think of osteoporosis. Osteoporosis, as you know, is a developmental disorder, otherwise called marble bones. Sometimes it is hereditary also. Cousin of this osteoporosis is pycnodysostiosis. Both are almost same, except in pycnodysostiosis there are differences that could differentiate osteoporosis from pycnodysostiosis. Actually, pycnodysostiosis is a hybrid between craniocleidodysostosis and osteoporosis. So the common factor of osteoporosis is dense bones, that is there. In addition, dysplasia of the clavicles, either partial or complete absence of the clavicles. And then you have got a obtuse angle of the mandible, and you get what they call terminal phalangeal acrosteolysis, resorption of terminal phalanges. Then there is a rare disease called Cushing Syndrome, which is dysplasia. Generally, these children do not survive long, but look at the rib cage. It is almost constricting the thorax and lungs, and this is Cushing Syndrome. Next is achondroplasia. Achondroplasia is the most common type of dwarf that we come across because their intelligence is normal, their longevity is great. That's why the most common dwarfism that we encounter in daily life is achondroplasia. And then in childhood, how do you recognize? In fact, in utero, by ultrasonography, you can recognize the dwarfism, namely achondroplasia. Look at the thoracic cage, dumbbell-shaped tubular bones. And the spine also, as you come down, the interpedicular space is narrow. And then we come to thin ribs, or the so-called ribbon ribs. As it is, the ribs are flat, not so cylindrical. But then if they are thinned out and ribbon-like, you can get an osteogenesis imperfecta. You recognize this because of the multiple fractures and also osteoporosis that exists along with it. Melick needle syndrome is a rare syndrome, but if you find thin ribs, you think of that syndrome. Gorham's syndrome, so-called disappearing bone disease, vanishing bone disease, where for no reason the articular ends or the middle portions of the ribs are resorbed. Sometimes contiguous ribs are resorbed too. And then neurofibromatosis, particularly intercostal neural fibromatosis, they erode. Not only they erode, there is what is called mesenchymal bone dysplasia associated with the neurofibromatosis. That's why you get thin ribbon ribs classically. Marfan syndrome, Marfan, M-A-R-F-A-N, Marfan syndrome, where there are multiple disorders say for example, long arachnodactyly, posterior vertebral scalloping, and thin ribs, and of course cardiac valsalva aneurysm also you can get, and medial necrosis of the ascending aorta. These are all some of the dislocation of the lens. These are some of the clinical features, but you identify, or when you say there are 10 different, you go on investigation. You see, as normally, when you see the chest radiograph, you think of the various entities, and if only prove by looking at the various clinical, laboratory, and even other imaging examinations. Osteogenesis imperfecta. Actually, there are 4 varieties, clinical varieties and radiological varieties also, 4 varieties. Osteogenesis imperfecta, the classical blue sclera is not present in all the 4 varieties. But the classical finding in radiological of the bones is thinning of the bones, gracile bones, osteoporosis, easy fractures, easy bending. That's what you see in the thoracic vertebrae, planar vertebrae, multiple planar vertebrae, compressions of the vertebrae, and in the leg bones, bowing, thinning of the fibula and tibia. And why I showed that is in osteogenesis imperfecta, that we are talking about the reflection upon the chest. Look at the ribs, multiple fractures, multiple lucencies due to osteogenesis imperfecta. That's how, from the chest alone, we think of it. Piles disease, metaphyseal dysplasia. Look at the medial ends of the clavicles. They're widened, splayed, bilateral, symmetrical. And that you can diagnose by looking at the radiograph. And if you think, if you suspect any congenital dysplasia, Piles disease is one of them. Axolosis is not actually a congenital, but congenital deficiency of the enzyme producing a metabolic disorder. Diffuse sclerosis of the bones because of the calcium oxalate crystals are deposited in the growing ends of the bones. Look at the posterior ends of the ribs, bulged, dense, almost bone in a bone appearance. Same thing in the thoracic vertebrae also. This is axolosis. Primary axolosis. Secondary axolosis you can get renal disorders, but we are not talking about that. We are talking about the primary axolosis. Eventually, there is evidence of secondary hyperparathyroidism in these radiographs. Look at this, another case of axolosis. Look at the medial ends and lateral ends of the clavicles, proximal ends of the humeri, the scapulae. All these are dense bands of sclerosis. Now we come to another entity called fibrosis dysplasia. This is more common. And in fibrosis dysplasia, skull is very often involved. And then ribs also. The next in common is the ribs. Any elongated, expansile, benign-looking lesion with a ground glass appearance, we think of fibrosis dysplasia. May involve, it may be monostotic, may involve one rib, may be polyostotic. And then there is a syndrome called Albright syndrome, where it is polyostotic, not only the ribs, but the other limb bones are also involved. And there is sexual precocity in girls with skin pigmentations. That is what is called Albright syndrome, fibrosis dysplasia. And then other entities include spondyloepiphyseal dysplasia. It is also a developmental disorder. Not only the epiphyses are dysplastic, but the vertebrae also. Look at the flattened type of vertebrae. Unless you take the limb bones also, you can't really diagnose from this vertebra plana or flat type of vertebrae that it is spondyloepiphyseal dysplasia. Spondylometaphyseal dysplasia, you can get lots of mucopolysaccharide syndromes, you can get flat type of vertebra. Of course, there is anterior inferior peaking in those vertebrae, in those syndromes. Now we come to metabolic bone disease. How does it reflect upon the thoracic cage? Vitamins, either excess or deficiency, common, vitamin D, vitamin C, minerals, aluminum deficiency, iron deficiency, metals, and then hormones, enzymes, muscles. Rickets, common vitamin D deficiency is manifested in terms of rickets, rachitic rosary you can get, beaded appearance of the anterior ends of the ribs, costochondral junctions. Why that beaded appearance? Because of the lack of calcium, the osteoid compensates and excessive osteoid is deposited, as though to compensate for the calcium deficiency. That's why you get beaded appearance. Cupping of the metaphyses. And then scurvy. Scurvy is due to vitamin C deficiency, not commonly seen. Here also you may get anterior costal cartilage cupping, but then osteoporosis is common in scurvy. Now we come to endocrine glands. Hyperpituitarism, acromegaly. How does it manifest? At one time we have described big first ribs, but it is not substantiated in many cases. Few cases we have seen, so we describe that sign. Anytime you find a large first ribs, think of acromegaly. And then in the vertebral column, there is posterior scalloping, and occasionally you find osteopenia also. Now Cushing syndrome, either iatrogenic or due to adrenal insufficiency, delayed bone maturation, particularly in children. Osteoporosis is the main feature, and pathological fractures, excessive callus. When there is a fracture, there is abundant callus, although people call it pseudocallus, but there is excessive new bone formation is there. Osteonecrosis at the articular ends of the bones, heads of the femora, heads of the humeri, metacarpal heads, and infarcts. Bone infarcts are also common in Cushing syndrome. And then septic arthritis, which is also superimposed infection. Look at the osteoporosis of the vertebral column. How do you diagnose osteoporosis apart from, say, differentiating from osteomalacia? The cortex is thin, like as if it is drawn by a white pencil. There is marked differentiation between the cortex and spongosa. The center of the vertebra is almost loosened. And then iatrogenic steroid therapy, you can get cardiomegaly. Look at the left ribs. Excessive callus. Not only excessive callus, there is extra pleural fat also accumulates because of, and then in the vertebral column, look at the T5 vertebra is fractured, so particularly the superior end is sclerotic. That is what is called callus, pseudocallus formation. Another steroid therapy, look at the multiple fractures on either side and osteoporosis of the bones. Again, another steroid therapy. I'm showing you multiple cases so that to impress upon you that you should be aware of these complications, because for anything today steroids are prescribed as if it is a panacea for all the evils. Anyway, look at the left side of the chest. It looks like as if there are multiple coin shadows, but these are all healed fractures of the ribs, bilateral, almost symmetrical. Same type of healing fractures on your right side of the film. Again, once again, coming back to osteoporosis, wedging of the fractures is common, and then central lucency because of the trabecular resorption. We come to the skeletal angiomatosis, otherwise called hematemesis. This is frankly, on a plain film of the chest, in the ribs you may get a hemangioma, multiple lucent areas, the sclerotic border. Take a lateral view, the vertebrae may be involved. The classical appearance of, say, hemangioma in the vertebra, the jail bar appearance may not be there because it's all cystic, cavernous type of hemangioma, not capillary type of hemangioma. And of course on MRI of the spine, you can definitely diagnose because there is some fat also in these angiomata. Actually, these are called today hemangiolipomata. Look at the appearance on CT. Not really the polka dot appearance, but something like a brain, pseudo-brain appearance. Well, in this particular case, they have embolized because the patient is going to threaten for paraplegia because of the compression. Successfully embolized. And then this is the sclerosis of the vertebra. And look at the myelogram, faintly seen. The myelogram is obstructed at the level of the hemangioma. Now we come to the fluorosis. Fluorosis is worldwide, but very common in endemic areas. Particularly in India, there are certain pockets Punjab, Andhra. These are the areas where there is no protected water supply. They take water from the wells which are in excess of normal fluorine. And so as they go on drinking, they get the skeletal fluorosis, that is diffuse sclerosis of the bones. Most importantly, sclerosis of the bones may not affect calcification of the ligaments, interosseous ligaments, and irregularity of the margins, muscular attachments, and they have all sorts of pains in the bones and joints. Another case of fluorosis, if you look at the chest, almost the lungs are obscured by the sclerotic thoracic cage. In osteoporosis also you can get the same sclerosis. Remember earlier we told about osteoporosis and osteoporosis. But then the major difference is if you look at the ribs or the clavicles, the muscular attachments produce an irregular, wavy, sawtooth appearance of bone. Now we come to the infections of bones. How do systemic infections produce any changes in the chest? Tuberculosis is a terminal disorder. Most common is the tuberculosis of the spine. Often they come for a chest film and you find kyphosis and a paravertebral swelling, bilateral, symmetrical. This is most important in tuberculosis of the spine. Other infections of the spine may not produce that kind of a paravertebral soft tissue swelling, and it may go up or down the thoracic spine. Lateral view, look at the joint space. The joint space is narrowed, the articular margins are irregular, slight wedging of the vertebrae, typical of a tuberculosis of the spine. Here also there are external nodes, but if you look at the spine, the left side of the spine there is an area of lysis, and then an oblong, oval-shaped paravertebral swelling. That soft tissue swelling gives the clue that it must be infectious, most probably statistically tuberculosis. This young lady presented with supposed to be a breast mass. Actually, if you look at the CT of the thoracic cage, the costochondral junction, there is a soft tissue swelling, the central low attenuation area due to tuberculosis abscess. That abscess is lifting the breast, and she thought that it may be a breast mass. And often in a chest film, you find something like a coin shadow. Here, for example, the right upper zone. Tuberculoma is not uncommon, but here if you look at the first rib, there is a slight lytic area. And then you take a CT, it proves to be tuberculosis of the costochondral junction. Another AP and lateral of the thoracic spine, what do you find? Multiple lytic areas, as though it is metastasis. Sometimes even the pedicle may be involved. Or because of the young age, primary is not found out, so it's not metastasis, maybe lymphoma, but it proved to be multicentric tuberculosis. Beware, whenever there are multiple lytic areas, or if the joint space is narrowed, think of multiple or multicentric tuberculosis. Now we come to fungal infection. The triad of actinomycosis in chest is 1, infiltration in the lung in the form of a pneumonitis, localized pneumonitis, the action of the pleural thickening or in pleural effusion, and sclerosis of the ribs, irregularity of the ribs. This triad, if you look at a chest film, think of actinomycosis. Same thing in the spine also, sclerosis of the vertebrae, and on the left side there is a paravertebral soft tissue swelling. It is not bilateral and symmetrical. Not only that, in tuberculosis, only 15 to 20% of the time you get sclerosis, and that too not all the vertebral body. Actinomycosis is a slow, indolent infection, producing a lot of bone reaction. That's the major difference between tuberculosis and actinomycosis. Reacting bone is much more in actinomycosis. Sometimes you may find sinus formation also. Another case of actinomycosis, look at the soft tissue mass. It is involving the thorax, producing an abscess, ribs are destroyed, underlying pneumonitis, and a little bit of pleural reaction extending along the apex, actinomycosis. In children, there is what is called Caffeine Disease. Patient is irritable, running temperature, leukocytosis may be there, and the minimum thing they could do is take a radiograph of the chest. And the radiograph, incidentally, look at the clavicles on the left side. There is hyperostosis, as if there are fractures, but there is no history of trauma, but it's bilateral, linear, no fracture line is noted. And if you look at the mandible, there is also some periosteal reaction. It's typical of Caffeine disease, infantile cortical hyperostosis, they call it. Similarly, one on your right side, look at the ribs. It's almost healed. Synostosis of the ribs due to previous treated. Of course, there is no treatment except giving corticosteroids and conservative therapy. There is synostosis of the ribs. Gaucher. Gaucher is not so rare in India. Occasionally we come across. But how does it reflect? It's an infiltrative disease. And if you look at the chest, it's an enlargement of the heart, mediastinal adenopathy, and diffuse infiltration in the lung. Besides, the ribs are also widened, as if there's some narrow infiltration is there. Now we come to hematological disorders that reflect upon the skeleton. Sickle cell anemia. Commonly, it produces a rib within a rib type of appearance, or linear striations, and sometimes you may get a osteonecrosis of the humeral heads, because they're not uncommon sickle cell disease. And if you look carefully, the thoracic spine shows what they call Raynaud's phenomenon. That is vertebral notching, central notching of the vertebrae. Typical spine. Look at the fish mouth type of vertebrae, central notching on either side, with bulging of the intervertebral disc, classical of sickle cell anemia. Sometimes they call it H type of vertebra too. You may get in sickle thal anemia too. Now thalassemia. The major difference between thalassemia and sickle cell is, in sickle cell, ischemia is common. Ischemia also occurs in thalassemia or polycythemia, but hypermedullinosis, extramedullary hematopoiesis occurs more in thalassemia. That's why you get widened ribs, particularly the anterior and posterior ends of the ribs, mild cardiomegaly. Cone view of the left thoracic cage. Look at the bulging of the, it's not the cupping as you see in scurvy or rickets. It's bulging as if there are masses. And these are mineralized. Where there is non-mineralized, that's why you get cupping. Here it is mineralized. This is due to extramedullary hematopoiesis in polycythemia. Another hematological disorder is mastocytes. Mastocytosis. Mastocytosis often produces diffuse sclerosis, occasionally anemia, or disseminated sclerotic. And then here also you may get a extramedullary hematopoiesis. Look at the bulge along the right cardiac border. This is extramedullary hematopoiesis in the posterior mediastinum. The lymph nodes are hypertrophied. And arthritis. What are the various arthritis that can reflect on a thoracic cage? Rheumatoid arthritis is the most common. Commonly, it involves the shoulders. And then impingement of the heads of the humeri towards the acromion. Resorption of the lateral ends of the clavicles. And occasionally you may get thinning of the ribs also. These are the three findings from which you can think of a rheumatoid arthritis. And there is another entity called DISH, or disseminated idiopathic sclerosing hyperostosis. If it is focal, confined to the cervical spine, you call it FISH, focal idiopathic sclerosing hyperostosis. Here it is disseminated. This is a flowing hyperostosis, not just osteoarthritis, and these are not osteophytes. Because this also occurs in elderly age, you may get both osteophytes also, but this typical flowing hyperostosis, this hyperostosis should include at least 4 thoracic vertebrae. Then only you call it DISH. Otherwise, ankylosing spondylitis you can get, and spondylosis deformans you can get. Ochromosis, another metabolic disorder called alkaptonuria, because the urine is colored, looks like an ochre color, and that's why it's called ochromosis. What are the major findings? If you take a film or the lateral film of the thoracic spine, first thing is osteoporosis. Then you may dismiss it maybe menopausal or senile. But then the intervertebral discs, nucleus pulposus, are calcified. Sometimes they are ossified too, with secondary osteophyte formation. This intervertebral disc calcification, or called chondrocalcinosis, is one of the characteristics of ochromosis. Now, infections of the lung. Any infection is systemic. So we have included infections of the lung, bacterial, viral, mycoplasma, Pneumocystis carinii, Cox, common, tuberculosis, fungal, and sometimes aspiration. Aspiration itself is not infection, but aspiration, as soon as some foreign material is aspirated, within 24 hours, organisms gather and produce pneumonia. Immunosuppression, easy to get infection, steroids commonly used, diabetes, any chronic disorder, debilitating condition can produce superimposed infection. HIV positive nowadays, chemotherapy, and post-transplant also, they are subjected to infections. This is just to show the pneumonia air bronchogram in the right lower lobe. Another bronchopneumonia, bilateral, symmetrical. Usually as occurs in step 2 or staphylococcal pneumonia. Mycoplasma pneumonia, just a patch of infiltrate in the right lower lobe. There's no pleural reaction. Staphylococcal pneumonia, earlier I was mentioning staphylococcal pneumonia. This is a consolidative form. In the sense, generally, if it is single, you get a round type of pneumonia. Bulging fissure, adjacent fissure is bulged. Of course, in Friedlander's pneumonia also you can get bulging fissure sign. And if it is bilateral, multiple round pneumonias. They may break down any time. Staphylococcal pneumonia. And when they break down, follow-up films may show a nematocele-like appearance, central lucency, simulating a cavity. Klebsiella, as I mentioned to you earlier, is also common, non-descriptive infiltrate and consolidation in the right upper lobe. Resolved pneumonia occasionally may show as a patch of infiltrate, the right upper lobe. Another fungal infection, blastomycosis, not so common, but still you can get non-descript infiltrates. These are two different cases. And the one on the left side shows bilateral interstitial type of disease with coalescence of the interstitial infiltrates. One on the right side is a small patch in the right middle of area, proved to be blastomycosis. This young girl had flu to begin with, and then suddenly she has developed respiratory distress syndrome, bilateral homogeneous shadows with air bronchogram. Pneumocystis carinii, with immunosuppression or even without, one can get Pneumocystis carinii. There are various manifestations in the lung. 1, it may look normal. 2, it may look like miliary tuberculosis. 3, bilateral symmetrical alveolar opacities. These are some of the manifestations of Pneumocystis carinii. Tuberculosis chest. Common varieties, cavitation, infiltration, caseocavernous lesions, fibrocavernous lesions. These are tuberculoma, these are common. But consolidation in tuberculosis is rather rare. Simulate pneumonia, that too basal infiltrates. Generally you don't think of tuberculosis. Apical, superior segment of the lower lobes, you think of tuberculosis. And anterior segments also. And adult primary, there is, you see earlier, we didn't encounter much of adult primary tuberculosis manifested with lymphadenopathy. In the child only we used to see if there is a gastrointestinal lymphadenopathy, maybe it is primary complex. And then today we are seeing in adults also. Consolidated area. Who would think of a tuberculosis in this particular? You think of pneumonia or abscess or some other lesions, but not tuberculosis. This is proved to be tuberculosis. Again, various manifestations of tuberculosis, lymphadenopathy, right paratracheal, and hilar lymphadenopathy, again in all the films. And one on the extreme right side, you see right hilar adenopathy with perifocal exudate. Now Aspergillosis, another fungal infection. There are 4 types of forms: primary allergic form, also primary invasive form, secondary non-invasive form, secondary invasive. These are the four types of aspergillosis. And radiologically, what do you see? It may simulate bronchopneumonia, simulate segmental pneumonia. It may simulate, say, for example, miliary tuberculosis, miliary aspergillosis, extreme cases. And secondary aspergillosis, that too, bronchopulmonary type of aspergillosis, you find again patchy, evading type of pneumonias. Today, he or she comes with a cough and expectoration, you find a patchy pneumonia, you treat with some conservative therapy, after 3 or 4 days, this disappears, another pneumonia. This is typical of bronchopulmonary aspergillosis and central bronchiectasis also. Secondary aspergillosis, a fungus ball, any chronic cavity, second invasion with aspergillus, and it is a fungus ball because it moves in decubitus, erect and supine positions, it moves. And it is nothing but blood, fungi and some debris. This is also a segmental type of bronchiectasis in bronchopulmonary aspergillosis. Pleural effusion is rather rare. In this particular case, somehow small pleural effusion is present at the left base. Now another fungal infection, blastomycosis, which we mentioned earlier. There are South American, Northern blastomycosis, but in India, only immunosuppressed patients get all sorts of fungal infections. Patchy infiltrates the right hilum with interstitial changes bilaterally. Pneumocystis, it may simulate a tuberculoma, just focal, or infiltrates. Pneumocystis carinii, we have already mentioned, another example of bilateral dense consolidation, one on the left side. On the right side, it is resolving. Alveolar consolidation is coming to interstitial and eventually it will disappear. Cardiovascular disorders, reflecting upon the chest, rheumatoid, we have mentioned already, systemic lupus erythematosis, scleroderma, periarthritis nodosa, vagus glands, and dermatomyositis. Rheumatoid. Rheumatoid nodule is unusual. There is what is called Kaplan syndrome, where you can get rheumatoid of the lung and superimposed in a pneumoconius. But this is a rheumatoid nodule. Rheumatoid infiltrates are also seen. Sometimes infarcts because of the vasculitis. Another case of multiple rheumatoid nodules in a male. These are necrobiotic nodules. Infiltrate and rheumatoid nodule. Sometimes it is a superimposed infection, not necessarily vasculitis. Scleroderma, you can get progressive systemic fibrosis of the lungs. To begin with, there is interstitial infiltrates. And sometimes, because of the aspiration, you get a bibasal pneumonia also. Scleroderma again, bibasal pneumonia, classical, and interstitial fibrosis, which you see on the left-hand side, leading to carpulmonale. Again, scleroderma, bilateral aspiration pneumonia. You can get thinning of the ribs also in scleroderma. Lupus erythematosis, usually you can get a cardiomegaly, mainly because of the pericardial effusion, oral effusion, and infiltrates in the lungs. This combination, patient is usually unable to take a deep inspiration. That's why both domes of the diaphragm may be elevated, and pulmonary infiltrates, oral effusions, and pericardial effusion. The combination of these findings is indicative of lupus erythematosis. Another case, cardiomegaly, pericardial effusion, patchy infiltrates at the right base. People say pathologically is always, supposing the patient dies for unfortunate reason or other. Then if you do pathological, there is infarction, but also superimposed infection producing these dense shadows. Another case of lupus erythematosis, cardiomegaly, left basal infiltrate. Now dermatomyositis. Obviously there is extensive calcification of the muscles, so there is no problem. Occasionally in scleroderma also you may get a soft tissue calcifications, not necessarily muscular calcification. Even in lupus, soft tissue calcifications are noted. Here, all the stripe muscles, linear, perpendicular, parallel type of calcifications in the muscles. There is one entity who should have included in the developmental variety, Myositis ossificans progressiva. Now they call it fibrodysplasia calcificans progressiva because all the time there is no myositis. All the time it may not be ossificans, it may be calcification. But again, muscular calcifications, it's congenital and developmental. And it should be distinguished from dermatomyositis. That there it is entirely different. Here there are other anomalies also of the toes and thumbs. Periarthritis nodosa. On a radiograph of the chest, you may just see cardiomegaly. They may have hypertension. But angiogram, you find multiple coronary artery aneurysms. That's typical of periarthritis nodosa. Vaginous gangliomatosis may be mistaken for tuberculosis. It may be associated with upper respiratory tract infection or isolated. It may be associated with renal abnormalities, nephritis. But however, the picture is patch infiltrates you may see, cavities you may see multiple cavities. So it's first you have to rule out tuberculosis and then come to a diagnosis of vaginous gangliomatosis. Occasionally they may take a biopsy of the kidney and then come to the conclusion. And other manifestation, chest radiology, pulmonary edema. Any systemic cause can produce pulmonary edema, not only congestive heart failure, renal, liver, all these failures can produce pulmonary edema. Cardiogenic, as we said already, non-cardiogenic, epilepsy, pulmonary edema can be seen. Uremia, pulmonary edema may be seen. The typical feature is bat wing bilateral distribution. Interlobular septa are thickened, so-called A lines, B lines, and C lines, and the vessels are blurred, hazy. And adult respiratory distress syndrome, most of these cases are terminal. Most of the cases are under ventilators. Several factors contribute, although in children it is mostly due to the deficiency of the surfactant, but in adults, several causes. Interstitial changes, alveolar changes, and added to this, there may be superimposed infection also. So often, when you take a portable radiograph of a patient who is under ventilator in an intensive care unit, when you see multiple shadows, you have to differentiate. Is it the primary disorder of pneumonia? Is it sepsis? Or is it multiple abscesses? Or is it superimposed respiratory distress syndrome? Common, almost every day, a patient in a cardiac ward, left ventricular failure due to hypertension, left ventricle is prominent like pushed heart, and interstitial edema. To begin with, it is interstitial edema. Eventually, it may go to alveolar type of edema and pleural effusions too. Adult respiratory distress syndrome, they call it stroke lung, stiff or solid lung, post-traumatic pulmonary insufficiency, adult hyaline membrane disease, congenital atelectasis, pump lung, fat embolism after a fracture, multiple fat emboli can go to the lungs and produce respiratory distress syndrome. Pulmonary edema. We said classically pulmonary edema should be bilateral, symmetrical bat wing. But if supposing for some other reason the patient lies down, favors to lie down on the right side, it may accumulate more on the right side. That is one of those cases. Or again it may happen that the left lung is diseased, maybe old tuberculosis, fibrosis, so edema is not symmetrical. Another case of pulmonary edema, look at the patchy alveolar infiltrates associated with interstitial changes, unilateral, the right side and the left side. And here again, there is an infarct and pulmonary edema. The arrow points out the pulmonary infarct and a bulged or dilated right pulmonary artery. Allergic vasculitis, penicillin was given, and pulmonary edema pattern. And not only pulmonary edema pattern, one of the alveolus has ruptured and you get interstitial subcutaneous emphysema. Routine congestive heart failure, cardiomegaly, arteriosclerotic type of heart, and pulmonary edema, both alveolar and interstitial. ARDS in a young girl, patchy infiltrates in the lung, non-descriptive. And pulmonary infarct, look at the wedge-shaped or oval-shaped density in the right thoracic cage, laterally located, pleural-based, pulmonary infarct. There are several manifestations in the chest. First of all, clinically you may suspect pulmonary infarct. You may not see anything in a routine X-ray. On the other hand, localized emphysema you may get. peripheral wedge-shaped opacity. Sometimes it is obscured by pleural effusion. In a young girl, 18-year-old, comes with a little distress, bilateral symmetrical hilar retinopathy with right paratracheal retinopathy. Commonly in our country, you should think of tuberculosis, but there are no infiltrates in the lungs. So mediastinal retinopathy in young people, 1, first tuberculosis, 2, lymphoma, 3, sarcoidosis. It is rare for metastasis to occur in younger people. Carcinoma of the colon, diffuse lymphangitic type of metastasis. Why there is air into the right dome of the diaphragm? The patient surgery, and it was inoperable, and they took a film of the chest, lymphangitic carcinomatosis. They didn't take a film beforehand, and often you can find pleural-based metastasis, particularly in the routine PLV of the chest. You may miss pleural-based metastasis or small metastasis, but CT helps. Lymphoma, mediastinal lymphoma, mediastinal retinopathy, little pleural effusion on the right side. Leukemia, leukemic infiltrates, lymphadenopathy, and occasionally patchy areas of consolidation also you can get. If you look in the right film, look at the periosteal reaction along the proximal humerus. Multiple layers of periosteal reaction due to leukemic infiltrates and subperiosteal hematometer. Amyloidosis. Any terminal disease may lead to amyloidosis, such as chronic rheumatoid arthritis, congestive heart failure, multiple myeloma, etc. There are multiple calcific densities on the right side of the chest. It doesn't indicate, but you think of a amyloidosis. On the right side, you see just a cardiomegaly, nothing specific. Both cases are of amyloidosis. There is primary amyloidosis, the secondary amyloidosis. As I said earlier, secondary amyloidosis occurs in any chronic septic or non-septic malignant diseases. So that's the end of the story of how a simple radiograph can reflect a variety of systemic disorders, and you can suspect and thus examine the patient laboratory-wise, clinical-wise, and imaging the other parts to come to a conclusion.